right, let's go ahead and get started then. Welcome everyone to the CAP Grand Rounds. Unfortunately, Dr. Barbara Stewart's not here today, so I'll be doing the introductions. I'm Dr. Will Martinez, the Director of Child Adolescent Services here in the department. And it's my pleasure to introduce Dr. Niendam, completed her PhD in clinical psychology and subsequent postdoctoral fellowship at UCLA. She's been at UC Davis for the past 10 years and is currently an associate professor in psychiatry and a licensed clinical psychologist. As the executive director of the UC Davis Early Psychosis programs, Dr. Niendam oversees clinic and training activities and coordinates outreach and educational presentations within Sacramento and across California. She has developed 4 early psychosis programs in Northern California based on the coordinated specialty care model of early psychosis, sharing expertise on the course of early psychotic illness, evidence-based treatments for psychosis, and the use of standardized clinical assessments of early psychosis symptoms, functioning, and outcomes. She serves as the co-director for a HRSA-funded pre-doctoral trauma and adolescent mental illness internship, which is a collaboration with the UC Davis Care Center to provide trauma-integrated cognitive behavioral therapy to youth with early psychosis. With prior funding from the Robert Wood Johnson Foundation and UC Davis Behavioral Health Center of Excellence, she developed and tested a technology-enhanced data collection platform in multiple community-based clinics, demonstrating knowledge around gathering and using data as part of a cognitive behavioral treatment approach to improve early psychosis care in community settings. Her research focuses on implementation of data-driven approaches to mental health care in community and university settings to improve outcomes for individuals with early psychosis. And with that, if we could give her a round of applause.
Okay, turn myself on here. Thank you guys so much for inviting me to speak with you today about a topic that I'm very passionate about and one that I think that everyone could stand to talk about more. So I'm going to try to leave about 10 minutes at the end for questions, and Will's going to help me stay on track. So I want to disclose financial relationships. I'm a founder and shareholder in a digital health technology company. I won't be discussing any of that today. So for this presentation, I'm going to talk about what is trauma, the negative consequences of trauma, a model of trauma as a risk factor for psychotic illness. I'm going to do a brief review of evidence-based treatments for trauma, and then I'm going to move into treating trauma in psychosis. Okay. So I think it's important for us to just be on the same page about what I mean when I'm talking about trauma. We often use the word trauma in common parlance to refer to a variety of stressful or upsetting situations. But for here, in this presentation, I'm going to be talking about traumatic events. So these are things that involve exposure to an actual or threatened death, serious injury, or violence. And so these things can involve direct exposure, witnessing something in person, or even indirect exposure. So learning that a close friend or relative died or was exposed to a trauma. And then I think this is a very important piece as clinicians we have to think about too. This can also be repeated or extreme indirect exposure to the details of events for other people as part of our professional duties, and we call this vicarious trauma. So this isn't direct trauma to us or to our loved ones, but we are repeatedly being exposed to hearing these traumatic stories from our clients and their families. So there's also complex developmental trauma. And so this is where these different traumatic events are repetitive or prolonged. They often involve direct harm or neglect by responsible caregivers. They tend to occur at these points in an individual's development where they have more deleterious effects and really do compromise the child's development. So when we think about DSM-5 and the PTSD criteria, there are these symptom clusters: re-experiencing cluster, avoidance, changing cognitions about self or the world, and then changes in arousal that usually start or worsen after the event. We expect that these symptoms persist for a month and contribute to clinically significant impairment. So in children, what we tend to see is changes in play, becoming fearful of new things, separation anxiety, changes in sleep or somatic complaints, headaches, stomach aches, nausea. We also can see acting out, irritability, aggression, sadness, depression, a variety of things that bring kids into care. So different types of trauma. These things can be directly experienced again or witnessed. So emotional, physical, sexual abuse, neglect, interpersonal violence. I want to make sure that I highlight that bullying and harassment and discrimination are up here. Physical or sexual assault, community violence, natural disasters, accidents and medical procedures, and within the population that I serve, early psychosis, hospitalization can be experienced as traumatic, and then war. So as many of you probably know, trauma has negative consequences. And it's really being seen now as a public health issue because of its significant and far-reaching effects on the child in that developmental period, and then ongoing adult well-being in the lifespan. And this was strongly supported with the ACEs study. So we know, though, that exposure in childhood and adolescence tends to have the most significant consequences. And when we look at the ACEs study, we can see that if we could prevent childhood exposure to abuse and trauma, we could dramatically change negative outcomes for a variety of people. So some of those negative outcomes can be things brain-related, so cognition, one's ability to maintain attention, to learn, to remember, the ability to understand and process emotional information, facial affect, tone of voice, social relationships, having difficulty with friendships as well as family relationships, ability to function in work or school. Substance use is a very common consequence. We know that it contributes to poor physical health and disability as well as mental health disorders. Many individuals who experience victimization are at risk to be victimized again. And so intervening early is very important to prevent re-victimization. And then some of the worst outcomes, things like homelessness, suicide, and incarceration. So these are all of the negative outcomes that are associated with childhood trauma. So in psychosis, if we just focus down to those individuals who have psychotic illness, and I want to be clear when I'm talking about psychosis, I'm talking about a broad cluster of symptoms that can be seen in a variety of diagnoses. So things like hallucinations, having experiences in any of your 5 sensory domains that aren't tied to reality, hearing, seeing, smelling, things that aren't there, delusions, thoughts that you hold with conviction, again, that aren't really tied to what's happening around you and motivate your behavior and impact your functioning. And disorganized thoughts and behavior, so difficulty sort of communicating and directing your behavior in a way that seems logical. So psychosis. You can think about that as being in a disorder like schizophrenia, but these symptoms also appear in a variety of other disorders, such as mood disorders. You can see it in substance use. You can see it as a consequence of head trauma. You can see it in dementia. Okay, so in psychosis here, I'm talking about the development of psychosis in young adulthood, typically in a disorder like schizophrenia, schizoaffective disorder, or mood disorder with psychotic features. So trauma is common. Very common in our population. So if we look at the general population, a little under 7% will have a diagnosis of PTSD in first episode psychosis. So these are individuals who've experienced fully psychotic symptoms. It's about 1 in 4 to 1 in 5. It's a pretty high rate. If we look at youth who are showing early clinical signs that they may be at higher risk for a psychotic disorder outcome, we call those clinical high risk, up to 80% of them endorse a history of traumatic events and victimization during childhood. This is very common in this particular mental health population. For those of us who work in this population, we know how hard it is to diagnose individuals. So trauma is often poorly diagnosed in individuals with psychosis and serious mental illness in general. For example, in our clinic, we're often sort of trying to understand, is this hallucination of this voice or this sort of paranoid feeling related to trauma, or is this a psychotic symptom? And that's an active question. I'm seeing people nodding and hands are like, yes, I've seen that. So you're not alone. It's challenging. Okay. And we care about this. And I was talking with one of my colleagues about this because what we see is this history of exposure in psychosis. They are some of the folks who really struggle in treatment, and they have the poorest outcomes. So more severe symptoms, poorer social functioning, more likely to use substances, more often to go to hospitalization, have homelessness, and are at higher risk for suicide. So as an early psychosis researcher, I see trauma as one area where we can really have an impact to improve outcomes for the folks that we serve. So when we think about the development of psychotic illness, we've often talked about it as a vulnerability stress model, okay? And this was proposed by Zubin and Spring, where the individual has some sort of biological or genetic vulnerability for a particular psychopathology, and then exposure to stress leads the individual to surpass this threshold from absence to presence of symptoms. Okay, so you could think about this for trauma as a stressor, right? So you have some genetic or biological vulnerability to psychosis, you experience a sexual assault, and that stressor is enough to push you over the threshold. You could also think of it in terms of a stress sensitization model, where the expression of the illness comes after this major stressor in the presence of a biological susceptibility. But this really suggests that the individual is more vulnerable to stress after the emergence of the illness, and less stress is required over time to develop recurrent or more severe symptoms. So it sort of continues to keep the symptoms going. So we tend to see in our clinic folks where there's a history of stressors, a long history of stressors. They may have a genetic susceptibility, they may not, and they develop psychosis. And then I have clients where we don't really see a genetic susceptibility, then there's a sexual assault or something else that's very traumatic, and it's not long after that we see the emergence of psychotic symptoms. So it's kind of unclear right now how these two things interact, but really our models are based upon this concept. Whoa! What did I hit? Go back. There we go. Okay, trauma as a risk factor. So this was some work that Danessa Mayo did in collaboration with some people in this room, where we talked about this genetic biological vulnerability to psychosis. Okay, so there's been a recent meta-analysis that really talked about psychosis and adverse childhood events and reviewed over 30 studies and examined the relationship between trauma and psychosis, and found a relationship between childhood trauma and psychotic disorder outcomes, really making this link very strong. And while it's not causal in all cases, the high rates really suggest that it plays a significant role. So in this paper, what we talked about is there are some individuals where there's a genetic risk or vulnerability for the illness, and that this, in combination with trauma, leads to an abrupt change in their developmental trajectory. And so what we tend to see here is the individual begins to show poor emotion regulation and coping skills, changes in view of themselves and others, changes in cognition, brain structure, and increased sensitivity and vulnerability to stress. So they're made more vulnerable as they move forward in development. So in response to this change, some individuals begin to experience psychotic-like symptoms. So they may see shadows or have concerns about their safety. Then this makes them more vulnerable to the things that happen in their environment. So they are less adaptable to situations. They have heightened responsivity to threat. They may show increased high-risk behavior, such as substance use, as they have difficulty coping. And you can see how this could lead to the development of a variety of comorbid-looking conditions. And then they're more likely to experience trauma. And it sort of goes around in this circle, where increased vulnerability leads to more traumatic experiences, which escalates the cycle over time. This is one hypothesis. So what should we do about this? So a variety of trauma experts say we should be treating trauma. They have guidelines for the treatment of trauma. And Dr. Lowy, who's here in the audience, myself, and Dr. Waddell, who's our medical director, we wrote up a general overview of what this sort of treatment could look like for EP providers. I'm going to go over those concepts with you guys today. So the first place where we should start is screening for trauma. We should look for it and look for events and symptoms, and that should be part of our standard assessment. There are some very nice screening questionnaires that you can use in general clinical practice, and I encourage everyone to just make this part of what you do. So we use the PCL and the CAT in our clinic because it has a screener for events, and then it asks about response to the most significant event in terms of symptoms. And so that's our first pass as a self-report checklist, and then we end up using a much more detailed interview using the SCID to confirm a diagnosis. But I think just including these is a great place to start. Okay, and then once we know that the individual has a trauma history, we should provide evidence-based care. So what does that look like? Empirically supported treatments for PTSD use exposure to traumatic events, either cognitively or in vivo type exposures to reduce the cognitive and behavioral avoidance that maintain symptoms. So these are evidence-based practices for treating trauma. There's CBT, prolonged exposure, eye movement, desensitization and reprocessing, although I do want to highlight that the secret ingredient here is exposure and not eye movement, and cognitive processing therapy. In all of these, you do exposure. You can do it imaginal, you can do it in vivo, and there's a growing evidence base for a variety of other treatments, but the first line should be empirically supported treatments. So when we look to the research literature on established psychosis, so individuals who've had psychotic symptoms for years, we have a small number of studies that support using those evidence-based practices with exposure in psychosis. So here we have a study that showed a decrease in PTSD symptoms for cognitive behavioral therapy plus exposure compared to treatment as usual. Here we see a reduction in a variety of symptoms using EMDR with exposure versus treatment as usual. And then for EMDR and PE, both showed reduced PTSD severity. There's only one RCT of exposure-based treatments that's a really strong RCT, where they compared prolonged exposure and EMDR and showed that it reduced PTSD compared to waitlist control. But it was prolonged exposure, not EMDR, that resulted in full remission of symptoms. Studies of CBT without exposure show mixed results. So CBT decreased PTSD and other symptoms compared to TAU alone, but the next study in 2017 did not see the same thing. And so the user and colleagues thought that perhaps exposure may be the key to effectiveness. So why don't we do this? Why don't we all do this all the time? Right? I mean, it's like, here's the evidence. We should all just get up and go do it. But everybody's so hesitant. This isn't common in practice. And so why? And this was a question that Casey Cragen and I had. And so we did a survey of early psychosis providers across the US. And we wanted to provide some preliminary guidelines. We wanted to understand, what were you already doing? So we did a survey of 118 clinical experts and 121 programs across 21 states. And 3/4 of them reported barriers to treating trauma in their early psychosis program. So we can see that this is important, we see the value, and yet we're not doing it. So what were some of the barriers that these providers noted? One that we've already talked about: it's hard to differentiate trauma and psychotic experiences. So that can be challenging just at the onset. Trauma and psychosis symptoms can interact and exacerbate each other. And so sometimes clinicians feel hesitant or worried, if I treat this traumatic event, do I make the person worse? Am I going to make the person worse? I don't want to do that, so maybe I won't treat them. And many of them noted that they didn't feel adequately trained, they didn't have enough supervision or guidance, and definitely not enough funding to be able to get the training and the supervision they needed to provide the care. So they all recognized that it was important and yet had troubles implementing it. So one of the pieces we've really been working on at UC Davis is developing an integrated approach to treating trauma in early psychosis care. We call it trauma integrated CBTP, or cognitive behavioral therapy for psychosis. And the person who helped write this paper is sitting right there, Joanna Folk. So what I'm going to tell you about is what we've developed and how we're doing it in our clinic at UC Davis. So this was supported by HRSA. We were trying to develop a psychology workforce and also meet an unmet need in the area. And so we were working on trauma in early psychosis and youth at high risk. So this was a collaboration between our clinic, the EDAP clinic, and the care center at UC Davis. I'm not sure how many of you know, they're really experts on trauma. They provide a lot of trauma training, TFCBT, PCIT here in Northern California. We focus on individuals ages 12 to 30 who are within 2 years of psychosis onset or at clinical high risk. And we built upon a foundation of TFCBT. And for those of you who aren't as familiar with TFCBT, it has many components of prolonged exposure and cognitive processing therapy. We also threw in a little bit of DBT because some of our folks need it. But really, it starts out foundationally with psychoeducation and coping skills before you get to the point of exposure and safety planning. Okay, so for us, we felt that that was a good place to begin for our clients. Okay, so this is what our clinic looks like. We have what we call the coordinated specialty care model for early psychosis. So we have a team-based approach where we meet every week. There's lots of physician time. Everyone has a clinician, supported education, employment, a family advocate, peer case manager, and a bunch of groups. This is pretty comprehensive. Okay, so the important piece that I'm going to talk about is at the level of the lead clinician. So the first one is assessment. So we assess psychosis symptoms using the structured interview for prodromal syndromes, the SITS, and then the SCID, the structured interview for DSM. I mentioned to you before, we use the PCL for adults and the CATS for youth. That's a nice parallel form. And then I mentioned that suicide is a pretty significant outcome, as well as non-suicidal self-injurious behavior in individuals with trauma and in individuals with psychosis. So we use a pretty detailed assessment. We use the Columbia Suicide Scale. Then we try to prioritize the treatment approach. So this is a decision tree we've created where we try to really understand the level of severity of psychotic-like symptoms and trauma symptoms. So do we see here, for example, trauma is recent, for that example I gave you where someone had a sexual assault and then the symptoms developed rapidly. So here, trauma is recent event or trauma symptoms are prominent, and then the psychotic symptoms or attenuated positive symptoms are stable and secondary, would suggest that you complete the SCID and the PTSD interview and move pretty quickly into TI-CBTP. Same here, psychosis is stable, let's move forward. What if they're not stable? What do we do then? Oh, now we have psychotic symptoms are prominent and severe, and there's trauma present. Focus on stabilization of psychosis. Go back and complete that PTSD interview again when stable, and then begin to initiate treatment. So trying to help people just think through those assessment pieces and when to initiate what kind of treatment. So within the TI-CBTP for psychosis right here, you start out in a CBT framework with your case conceptualization, go to safety planning, you provide general psychoeducation. If you're going to move into TI-CBTP, it's going to be about psychosis and trauma. So you would, from a TI-CBT framework, if they had sexual abuse, physical abuse, you'd be pulling out those handouts and talking about sexual and physical abuse. You begin to engage the family and the support network in the treatment. 90% of these folks live with other people. You need to tell them what's going on too, and include them in the work that you do, because that helps to stabilize the individual in their setting. Try to engage them in group, support education, employment, you're tracking their symptoms, seeing how they're doing, revising your case conceptualization, going around for a little while, building what we call that foundation before you start to do other work. Everybody knows what you're talking about, you know what's happening with the client, you're building stability. And then you start to work them through the TF-CBT components. So you start with psychoeducation, as I mentioned, making sure they understand common reactions, biology. You've worked through, you have a good conceptualization of what's going on. You've laid that psychoeducational foundation. Now we're going to do some skill building. What sort of maladaptive coping strategies are they using, and how do we replace them with more adaptive coping strategies? We're going to look at relaxation, affect recognition, regulation, cognitive coping, whatever sort of skills you need to build in as part of that PRAC component of TF-CBT. Again, enhanced supports, making sure support persons know these skills, can be supportive in skills. For individuals who tend to engage in more risky or self-harm behaviors, that you've got a nice safety plan and people are aware of what steps the person needs to take to keep them safe and how they can support. Do some safety planning, plan for relapse. Make sure if individuals are still engaging or in situations in which ongoing victimization could occur, that you've worked with them and done some safety planning there so that they understand what a healthy relationship is, they're able to avoid further victimization. And then you can move to exposure. You want to do this gradually to maintain stability and continue to monitor them over time. It's stressful. It's stressful to do exposure for the clinician. It's stressful for the client, for the family. And so you want to make sure you go slowly. And if things don't go well or they start to get distressed, then let's back up. All right, let's restabilize our foundation. What coping skills do we need to reinforce? What other supports do we need? What is it that is going to help you feel stable enough to keep going? And then you keep going. We see lots of people break down right here. Like, they don't even keep going. They're like, you're doing well, because for anyone who's done TF-CBT, after the prac, people are like, I feel so much better. I'm done. They're like, no. Even clinicians are like, they're so much better. No. So you have to, this is your essential component. So you have to keep going. And so coaching everyone. And this is where I think supervision is so important, coaching everyone through this. So we'll do imaginal work before we get to any sort of in vivo work. And so we do complete narratives. We find that that's a nice way to do it in session and to help the person work through the feelings they have, to work through the thoughts they have, challenge any remaining sort of maladaptive cognitions, address any avoidance they may have. It presents a nice contained way to do it. There's chapters within TF-CBT of making meaning of experiences, and our clients have been incredibly responsive to this. Now, some of you in the audience might be going, but TF-CBT is for children. Yes, it is, and it's really helpful for other people too. So, we work in a transition age youth population. And again, our choice in following this is because there's a good foundation of skills and knowledge that you build for folks before you move into prolonged exposure. Or before you move into exposure. So it just helps folks feel more stable before they get to exposure. And you don't have to do the narrative with a caregiver. Some of our folks have chosen to do that. You can just do it with the clinician, like prolonged exposure if you want. We've had it, people do it with roommates, partners, whomever seems like a safe person that would be supportive. All right. You're trying to go for 1 month of stability before you move here. So that's where as you're moving through these pieces, you're really watching symptoms. And that's where measuring symptoms is really important. So this is where I'm going to pause and say, let's talk about community, culture, and language. In doing this work, I've learned a lot in terms of working in Sacramento. Our clinic serves Medi-Cal, uninsured and undocumented, sort of a very diverse population. And with some of the changing political events that have happened over the past few years, there's been a large rise in community violence and community trauma. And so we've seen that come in and play a role in the things that we're working on with our clients and families. So it's really important to keep in mind that exposure to trauma, the likelihood of being exposed to trauma, can really depend on your sex, your age, your racial and ethnic identity, your sexual orientation, where you live, your community, and the socio-political situation in which you live. So some folks are more likely to come in with this than others. You can have a very different response to trauma. At an individual level, how you process that experience, at a family level, how the family makes meaning of that experience, and then at a community level. How does your community understand what has happened if it's a big event? So some of the things we've seen, does the family blame the victim? Was it their fault that this thing happened? That's a really important piece to sort of understand about the beliefs of that family as you're working through the psychoeducation and trying to understand where that piece comes from. War. We've had a number of our clients come from situations where there was civil war. And so we heard stories of civil war and we were like, this is horrible. This must be so traumatic. And the client's like, well, everybody experienced that, and that was just what it was. Actually, the most traumatic experience was this assault. And we're like, got it. So for us, as clinicians, we have to really take into account our own experiences and how that leads us to judge the traumatic nature of what our clients report to us, or the severity, and to keep that in mind too. And avoidance versus coping. How do, we're often apt to label things as avoidance, when sometimes within that family or within that culture, that's appropriate coping. And so to really try to understand things within the context of the individual and their culture. Access to appropriate treatment. Even within communities like this, many individuals don't have access to appropriate care. And we see here in Northern California, in the Valley, in rural areas, there's very little evidence-based practice. So that's a big issue in terms of serving clients who need to be served, but also training providers who need to be trained. Telehealth can hopefully help bring more access to other communities, but that's something that's still building. There's some very exciting developments in other communities, like for example, internationally, there's a significant lack of care, but some folks are developing really unique and exciting approaches to providing care with paraprofessionals in their communities. And so it'll be very interesting to see what comes out in the next couple of years about how to address the needs of communities. We like to recommend, it's not perfect, but it's a good place to start, is the DSM cultural formulation as just one way of engaging with families around their understanding of what's happening, their experiences and their reactions. So how do they understand this traumatic event? What meaning do they make of it? How do they explain it to their family members? What would be their typical way of coping with it? Really just taking that time to understand the context within which the person lives before you jump in with your evidence-based practice. Language. Language challenges. There's a significant lack of access to qualified professionals with language skills. And as a result, we rely on interpreters. And for me, I grew up speaking Spanish in Kentucky, which means I can read it, I can write it, and I can understand it, but you don't want to hear me talk it. So I can understand oftentimes what families are saying to me, but I don't feel as comfortable speaking back. And so I've worked a lot with interpreters, and it's really hard. And we are so lucky to have a number of bilingual, bicultural staff, Spanish-speaking staff in our clinic. And so we've been able to learn about these misinterpretations we've had. And so sometimes you can lose the concept during interpretation. So we had this one mom that we were talking, and the traumatic event was the shooting death of one of her sons. So mom, two sons. One son is in our clinic and has developed psychotic illness, and his brother was shot and killed. And so we were trying to understand if mom also had psychotic symptoms or if she was having trauma symptoms. And so we were trying to see if she had hallucinations. And she said, I always feel like my son is with me. He's my son, and he's always with me. And in hearing that, we were like, that doesn't sound psychotic. But these are things where sometimes a very direct translation, you can lose that. So we've really tried to step back and make sure support persons understand the symptoms, concepts, and relapse plans in their primary language, and spending a lot of time ensuring understanding and trying to explain our concepts before we're assessing or treating them. Am I making sense? Okay. So I'm gonna give you a case example. So based on a real case, there's even more that's not on here that's super exciting. So Jose is a 17-year-old Hispanic male. He presented with his biological parents to our clinic after hospitalization for his first manic episode with psychotic features. He started on medication, stabilized very quickly. He had witnessed a shooting in his neighborhood school 3 weeks prior to his first episode. So very clear traumatic event, became dysregulated pretty quickly and ended up in the hospital. At this point, he was refusing to go to school or go outside his home, which makes sense. Okay, so psychoeducation, we spent a lot of time identifying for him what his symptoms of mania were. And they weren't just, I was feeling good. What those things were that his parents and he saw as unusual or abnormal or a change. What his symptoms of psychosis were, and his trauma symptoms. We worked really hard to identify his reactions and trauma triggers and the role of avoidance. There was a lot of I don't remember, I don't know, it's fine. Both from him and his parents, who are monolingual Spanish speaking. Because he was out of the hospital, he was doing okay. He was okay, he's okay, right? And we were like, he was getting straight A's at school and had lots of friends. He's not okay. So working with them over time to really understand where he was still experiencing trauma triggers and various reactions and what avoidance meant. Then we did some skill building. Relaxation skills were very helpful for this young man, but again, lots of avoidance. And so we had to use SUDS ratings, subjective units of distress ratings, to capture his distress. And so, trying to go outside the clinic. Let's take a walk. No. Rate your SUDS, like right there at the door, because he was so avoidant of even trying that we couldn't capture SUDS ratings. And so trying to get him to do anything and see how he was becoming distressed and then engage in coping at that time. He had a very hard time articulating his thoughts. And so again, we had to do a lot of this. It's not exposure to the trauma, but it's exposure to things that were triggering for him. And so to get him to be able to articulate his thoughts, identify his feelings, and the distress he was having. We engaged his parents in psychoeducation sessions. They had very little mental health vocabulary, honestly, very little understanding of the school system and the consequence of their son not returning to school. We spent a lot of time just helping them and talking with them through these things multiple times. They had to hear it multiple times because there was no framework that we were building on. We were starting from the ground up and building up. He taught them about his coping skills because they were also very avoidant. And so at home, he would get a little dysregulated and they didn't quite know what to do. And so he really worked with them on teaching coping skills. And again, we reviewed the role of avoidance. Then we did relapse management. We did a safety plan. So they understood his warning signs for mania, his warning signs for psychosis. We discussed community safety so that he felt safe in his community. He was stable for 1 month, and we started doing exposure. It was interesting. His exposure, he really wanted to go back to school. And so we did a lot of imaginal work just around going back to school, what it would be like to walk on the campus, to walk across the park, like really working with him, doing his SUDS ratings, looking at his coping and his thoughts. And then we did campus visits, where we went out and just walked with him on campus. And then let's walk into student support. And we even grossly underestimated the reaction he was going to have to a pretty simple exposure, like going to the parking lot. It took 2 hours for him to walk across the parking lot onto campus. But he did it, and it was amazing. And within 4 weeks, we had him re-registered for school. And then things went back a little bit. He got a little avoidant again, and we had to go back and do a little bit more support. But he's back in school. He's finished his exposures. He shared his story with his parents, and they wrote him the most beautiful letter about how proud they were of him and how much they had learned from this experience and how they were committed to continue to support him. So it was a very exciting example of how you can bring these two things together. Oh, the challenges. Okay, managing challenges. So in psychosis, cognitive impairment is common. It is a brain-based disorder. We have difficulties with attention, memory, learning. You're gonna see it here too. So we work very hard to keep it very simple, very concrete, lots of practice, lots of visual aids. It requires a lot of rehearsal, and that's okay. Negative symptoms, so this is the loss of motivation, interest in activities, blah, I'm not gonna talk much, I'm not gonna have a lot of affect in connecting with you. It's a very debilitating part of psychotic illness. So we do a lot of CBT there, behavioral activation, pleasure ratings, emotion induction. We do a lot of writing and drawing. That seems to be helpful for many of our clients in terms of being able to express themselves and then reflect on their feelings and then talk about their thoughts. So that's been one very helpful way instead of trying to always get them to talk to you. Recurrent crises. As I mentioned before, many of these clients, have poor coping skills, poor emotion regulation, lots of suicidal ideation and behavior and SSI. So really trying to manage, as they call in TOCBT, the cows. There's lots of crises. How do you manage those? Enhancing supports, making sure they have community services, trying to bolster that family, however you want to define family system, so they can help to keep things stable. Again, DBT has been incredibly helpful for us using distress tolerance techniques, other DBT skills. For these folks, it's been really useful. And then parent training. Sometimes our parents, their lives are just really chaotic. And so if that's like their world's chaotic and this child has a trauma and they feel chaotic on the inside, if we can help to calm down the chaos in the household, that sometimes gives enough space for the parent to be present for the young person or for the person who's struggling with these symptoms. Family history of trauma. We have lots of family members who have their own trauma history. And so being able to sit in the room and do psychoed about trauma for that parent or that loved one, spouse, partner, whomever, is exposure. They're doing trauma treatment too. And that can then contribute to avoidance or the kid falling out of care. And so really being mindful for those parents or caregivers or other support persons. Are you providing trauma treatment for them too? Do they need a referral? How can you, we have one young woman where mom has she's had multiple sexual assaults and a history of domestic violence, and her daughter has been sexually assaulted twice. So, we've gotten her mom linked with care. And so mom's now gone through enough that she can sit in the room with her daughter who's going through trauma work. But then the clinician always has to check in with mom after and be like, how was that for you? Link it to mom's care, encourage mom to follow up if need be, praise, we'll see you next week. So it can be really challenging. Okay. Rapid disclosure of trauma. For anyone who does trauma work, you've experienced this. The first session, here's all the horrible things that have happened to me, very rapidly, sometimes without feeling. I've told this so many times, I'm gonna tell you everything right now. Nope, stop the exposure. That's exposure, and it's not useful. It's not useful for you, it's not useful for them, right? Because they're not connecting with it. They aren't doing it appropriately. So making sure that they understand the process and what you're trying to do, and that you will get to that, but not right now. The reality of the incident. Did this traumatic event actually happen, or was it psychotic? We usually engage collateral informants and really try to understand from whomever we can talk to what happened at that time. We review records. I had one young woman who, over the course of the first 6 months of treatment, disclosed that she'd been sexually assaulted by peers at her school in the bathroom. And it was around the same time that her psychotic symptoms started. And so for a while, we were like, did this happen? Did this not happen? We're not sure. And it was about 8 months, 9 months into treatment that finally her mother disclosed, well, before she got psychotic, she stopped wanting to go to school. And so we got this information that it was like actually something maybe did happen separate from her psychosis. So sometimes it'll come out over the course of care, but to look for that additional information. And regardless of whether it was real or not, it's distressing. So you can process the distress around the experience. Yes. Okay, I'm almost done. Yes. Okay. I already mentioned, we're afraid of this. Don't be afraid. One of the things I like to remind people that even psychoeducation is exposure. Just saying trauma, just saying sexual abuse, that's exposure. You're doing it. You're doing it, even at the beginning. Keep going, keep going. You won't break people. If you build that foundation, if you're mindful, if you're thoughtful, you won't, bad things aren't gonna happen. Move forward slowly, shore up those skills. Take care of yourself. Manage secondary traumatic stress. Make sure your environment's trauma informed. This is really hard work. Being a mental health provider is really hard work. Working in serious mental illness and doing trauma work is exceptionally hard. So please take care of yourself. So we've been doing this since 2015. We've had about 29 youth. This is some basic stuff. Majority of them are first episode psychosis. 55% of them had PTSD. We had a third that completed some of our components, while 12 hadn't at the time of assessment. So basically the takeaway from this data is that folks who are engaged in trauma treatment tend to have fewer psychotic symptoms when they come in, okay? Fewer psychotic symptoms, and they tend to be a little bit higher functioning. So, we have to work a little harder maybe to engage some of these folks who are a little more ill. And this really shows you that doing trauma treatment, you don't get worse. Because I think one of the incorrect cognitions that we hold is that people are going to get sicker if we do this. They will not get sicker. They will get better. Now, we also see that folks who didn't get the treatment also get better. So this isn't an RCT, I'm owning that, but they're not going to get worse. Okay, so we should treat trauma. People who are able to do the work tend to be a little bit more stable at baseline. They don't lead to an increase in symptoms. So in conclusion, this is a really important public health issue, and it's associated with really bad outcomes for our clients. Trauma symptoms are common. They contribute to poor course of illness. It may be a factor in the development of psychosis. We should be doing appropriate assessments and treatments, and exposure-based treatments have good evidence. And our preliminary evidence shows that it can be used in early psychosis and those at risk. There were a lot of people who did this work at UC Davis, the Care Center, a number of amazing interns and postdocs that contributed. I put in the slides, if you guys can get them, a variety of resources that you can look to, and then references to the work that I showed. So with that, I'm happy to take any questions. Yes. Yes. Manic with psychosis, yes. Nope. None. Yes. 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 So the question is, did Jose, this example that I gave, did he have any prior symptoms of psychosis, of mania, of trauma? And the answer is no. This was a very rapid onset. And so he represents what I would probably say is maybe, 1 in 5 of our cases that come in, this sort of traumatic event, rapid onset. Then we have a bunch of kids who've had a whole bunch of trauma, usually complex trauma, and then psychosis bubbles up. And then we have the kids who've had sort of some psychotic stuff, and then they're traumatized, and usually they're traumatized again, and then they get fully psychotic. But no, he did not. Yes, medication was part of his treatment.
question about this 1 month stability period. How do you assess for that? Is it functional stability? Is it symptoms?
Both. So we use the clinical global impression scale, and we sort of just try to see if at each session, and usually these folks are coming in weekly, have we been able to kind of get their hallucinations, delusions, disorganized thinking to a mild, sort of stable level, depression at sort of a milder or stable level, so that you're also not trying to deal with these other symptoms and stabilizing these symptoms at the same time as you're going into this, because you want that baseline so that if you start to do exposure and something bubbles up, you can catch it really quickly and be like, okay, we gotta reinforce some coping skills. So it's just a check-in. We use a scale and we just ask clients to tell us how they're doing on that scale. It's self-reported. Substance use, yes. Yeah, so if we have somebody who, it could be any not so helpful coping skills, substance use, self-harm, suicidal ideation, those are all things that we track as part of the stability. Yeah. Yes.
And so I'm wondering, how do you, what are your recommendations for working with social core values
This is when I wish. So the question, those of you who are farther away, is how do you deal with cultural manifestations of avoidance, particularly in the family, as you're working with these things? And I wish that I could teleport one of my colleagues here who's bilingual, bicultural, and has been working in this space to deal with just those things. And how do we provide psychoeducation? How do we engage the families in their care? So I think, so I don't have a perfect answer, because to us, it's an area of active exploration. I think we're trying to understand. So I can give you an example within the context of this case. And so here, where we sort of were working with the parents, we were getting a lot of, he's doing well, he's doing well, he's doing well. And we were like, how do we work with them? We sort of took a step back and asked both the client and his parents about what the long-term goals were for him. Where did they want to see him in 2 years, 5 years, 10 years? And everybody was like, oh, we want him married and living independently and doing all of the things that he used to do. And we're like, yes, that's what we want too. Okay, how are we not getting there? What are the things that are getting in the way? And so they were then able to see, because they were giving us this, he doesn't need to go to school right now. He doesn't need to do that. He's fine, he's fine. And we were like, but that's really getting in the way of him going. And so we just sort of worked with them on that goal, and then they were able to see, like, let's try. And as we sort of then started doing some of this stuff, we brought them along and allowed them to see how hard it was. And it wasn't just that, because he was giving them the like, it's not a big deal, it's fine. But then they saw him freeze in the parking lot and begin to hyperventilate. And then they were like, oh, this is much worse than we thought it was. But he taught them his coping skills. So we were able to say, Mom, can you help engage? And she was, and it was so great. And he was so grateful. So does that help? Okay. Yes. The question is, in general, how long does each phase last and how long does the treatment take? Oh boy. So this young man is finishing up treatment 42 months from start to finish. And so I think what we tend to see is the longest is this. If I could put in cows or managing crises, it would be like right here, right? Because people just get stuck. Like, there's so many crises, I can't even finish psycho ed. I can't even get to coping skills because they're homeless all the time. Like, you're just trying to do these two things and get the family in. If you can make it to here, yes, keep going, you know, but those are the longest. It's not regimented. We have not found some miracle way to get it done in 16 sessions. I'm okay with that because it's been working, but I can tell we have clients right now that we're just trying to get them through psycho ed and skill building. And it's really hard. It's really hard. In the back, do you have a question? Yeah. Yeah. Another crisis. Yeah. All right. Thank you, everyone. I appreciate it.